Good afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests have been mitigated. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section. Also, a link to the event survey will be shared at the end of the program. It is now my pleasure to introduce our guest speaker, Dr. Sana Ahmed. Dr. Ahmed is a third-year internal medicine resident at Northeast Georgia Medical Center and the incoming chief resident in internal medicine. Her academic work has focused on cardiovascular research with particular emphasis on heart failure, arrhythmias, and outcome-based studies. She has presented her research at multiple national conferences. Dr. Ahmed has a strong interest in preventative cardiology, including the use of advanced imaging and biomarkers to identify subclinical cardiovascular disease. She plans to pursue a career in cardiology. Join me in welcoming Dr. Ahmed.
Thank you, Jennifer, for the kind introduction, and thank you, everyone, for joining me this afternoon. And I'm very delighted to present on this topic, a proactive approach to heart failure prevention. My presentation is basically a clinical dossier based on the 2022 ACC, AHA, and the HFSA guidelines and the emerging paradigm shifts that's been happening. I do not have any disclosures or financial interests, and I'm not affiliated with any corporate having any financial supports of any sort. So let's start with the case. This is patient X. He is a 58-year-old male with past medical history of hypertension, type 2 diabetes, has a slightly elevated BMI of 29. Blood pressure in office is 138 by 85 mmHg. He has an A1C of 7.4. Patient states he feels fine. NYHA class is 1. There are no overt symptoms for this patient. From a heart failure perspective, where do we think that this patient falls? Do we think this patient is completely stable? Or do we think that something is brewing underneath and we need to have more interventions? There's just two options.
So I think from heart failure perspective, like it's an NIH class 1. As of now, the patient is stable.
Okay. So let's go over heart failure and we'll see how we develop this, okay? Based on the universal definition and classification of heart failure from the Journal of Cardiac Failure, which was issued in 2021, this is like an updated version. The proposed definition now of heart failure is clinical signs and symptoms caused by structural and functional changes, but this should be in collaboration with at least one of the following: an elevated BNP or any objective evidence of cardiogenic, pulmonary, or systemic congestion. Now, what counts as objective evidence for cardiogenic, pulmonary edema, or systemic congestion? This would be chest X-ray findings, any findings on echo, which state elevated filling pressures, hemodynamic measurements, which we could see with right heart cath or pulmonary artery catheterization, or at rest or with provocation exercise stimulated tests. This definition by itself does not include asymptomatic patients with structural changes or cardiomyopathies. Now, this society came up with the new staging of heart failure, which is divided into at-risk, pre-heart failure, stage C, heart failure, and advanced heart failure. Now, if you see, a lot of these terminologies seem similar or borrowed from the oncology side. This is to guide early recognition and intervention. We'll go further on staging in the follow-up slides. The other classification for heart failure, as we most commonly see, is the heart failure with reduced ejection fraction, which is your LVEF of less than 40%, mildly reduced ejection fraction, which ranges from 40 to 50%, preserved ejection fraction, which is an EF more than 50%, and improved ejection fraction. Now, this is also a new addition. The heart failure with improved ejection fraction is defined as baseline EF of less than 40%, but having a 10-point increase from baseline EF and a secondary measurement of an EF more than 40%. So let's dive deeper into the new staging. So in this, stage A heart failure is defined as patients who are at risk for developing heart failure. These are patients who are completely asymptomatic, do not have any structural or functional changes of the heart as well. The biomarkers will be completely normal. These are patients who are all just at risk of developing heart failure. So these are patients with hypertension, CVD, diabetes, obesity, patients who are exposed to cardiotoxins, patients with genetic variants for cardiomyopathy, family history of cardiomyopathies. These are all the at-risk patients. The next stage is the pre-heart failure stage, or the stage B of heart failure. These are also patients without any symptoms of heart failure, but they have evidence of one of the following, which would be any structural changes. They would have any evidence of increased filling pressures, which are usually seen on echo. And they would have like the risk factors which would cause the increased BNP in these patients, and they would have persistently elevated troponin levels as well, in the absence of any competing diagnosis. There's no other diagnosis which could justify this. Stage C would be all our symptomatic heart failure patients. So these are patients with current or previous symptoms of heart failure. Stage D is basically our advanced heart failure patients who are on medications, still not doing well, maybe needing advanced therapies, maybe requiring mechanical circulatory support. These are hospitalized despite attempts to optimize GDMT. Now, most of the time, actually, when we see patients in the hospital, we see patients in the stage C and D of heart failure. The patients in the stage B and stage A of heart failure are the ones we usually see in the clinic. So let's talk more about the patients we see in the hospital, the stage C and D of heart failure. The symptoms that these patients usually come about with is fatigue, exercise intolerance, exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and ankle swelling. The usual progression of the disease goes from exertional dyspnea, then they go to paroxysmal nocturnal dyspnea, and then orthopnea. The signs which support these things would be an elevated GVP, which signifies increased pressures, the lateral displacement of the apex beat, defined by basilar crackles, a third heart sound, and pitting edema seen on the ankles. This would be like the X-ray findings that we see with elevated filling pressures. There would be pleural effusions, there will be cephalization of vessels, the Kearney B lines, the increased CT ratio of more than 0.6. Now let's go more into the etiologies of heart failure. The heart failure is divided into heart failure with reduced ejection fraction, preserved, and the high output heart failure. The most common etiologies are your CAD, which can be ischemic or infarct. It could be non-ischemic cardiomyopathy, such as the infiltrative disease, familial, tachycardia-induced. We can have valvular heart diseases, toxic cardiomyopathies caused by drugs, immunotherapies, alcohol, hydroxychloroquine. Then there is the congenital causes of heart failure, cor pulmonale, and then we have the infectious causes like the Chagas disease, HIV, the autoimmune diseases like giant cell myocarditis and the lupus myocarditis. The most common causes for the preserved ejection fraction is your hypertension, CAD again, valvular heart disease, restrictive heart diseases such as our amyloidosis, sarcoidosis, hemochromatosis. Then we have our radiation therapy, constructive pericarditis, myocarditis, obesity, aging. High output heart failure, our causes would be thyrotoxicosis, AV fistula formations, obesity, cirrhosis, anemia, wet beriberi, chronic lung diseases, myeloproliferative diseases as well, which could be due to the extramedullary hematopoiesis. Now, this graph shows us the trend. This is the study which was done on the prevalence of heart failure from 2010 to 2023. For patients with heart failure with preserved ejection fraction, the most common cause continued to be hypertension through the years, followed by ischemia, which was on the second position and has now trended down because of early interventions. Other causes, which has trended up over the years because of early diagnosis, which is actually a good sign. And then we have our valvular heart disease, which stays around the fourth most common cause. For patients with reduced ejection fraction, ischemia has continued to be the number one cause, but its prevalence has gone down, which is a good sign that most patients are not undergoing the remodeling even after having the ischemic events. The second most common cause is now other causes, again because of increased diagnosis, followed by our hypertension, valvular heart disease. So if you see the most common finding, which is there between the prevalence in heart failure with preserved ejection fraction and reduced ejection fraction continues to be hypertension and ischemia. Those are the two main things that we can target to reduce the incidence. Now, what's the disease burden? The trend in mortality and hospitalization for heart failure. Heart failure is coming out to be like a global pandemic with an estimated prevalence of about 1 to 3% across different populations. The 5-year mortality rate for these patients is as high as about 50%, which ranges from stage A to stage D heart failure patients. Stage D heart failure patients have a very high mortality rate, as much as 50% in 1 year. So the heart failure prevalence is expected to increase by as high as 30% in the US by 2030. A recent US evaluation has also found that the total deaths caused by heart failure has gone up from 200,000 in 2009 to 300,000 in 2014. In 2017, there were up to 1.2 million heart failure hospitalizations in the US. This is a 26% increase in heart failure hospitalizations, and the death attributable to cardiomyopathies has also been increasing globally and has been documented. Heart failure kills at rates which is equivalent to common cancers. Now, I know this can come across as a big generalization, but I have some stats to support this. So what are the common cancers? The most common cancers have a 5-year mortality rate of as high as 58%. The most common cancers where pancreatic cancers has a very high mortality rate, and we're including even cancers like thyroid cancer, which has a low mortality rate. So the cumulative would be 58% within 5 years. For heart failure, across all the stages from stage A to stage D, the 5-year case fatality rate is as high as 59%. Because this is highly elevated because of the stage D heart failure patients who have an increased risk fatality ratio. We have standardized screening, which is fully covered by payers for cancer, but the biomarker screening largely remains uncovered still. The population at risk for development of heart failure, what we see is usually the stage C and D of heart failure. The stage A and B, which is the at-risk population, remains large and still largely uncovered and is quite a significant population. Half of the adult population in the US right now stands at the edge of this trajectory. Half of the US population has the risk factors for development of heart failure, which are hypertension, type 2 diabetes, obesity, CAD, genetic cardiomyopathies, and exposures to cardiotoxins. Now we will see the transition from being at risk at stage A to transitioning to stage B, which is the pre-heart failure stage. Stage A of heart failure is when you have the risk factors, which is you have the hypertension, diabetes, CAD, but you do not have any structural or functional changes. You will also not have any evidence of any biomarkers and will be completely asymptomatic. Stage B heart failure patients, though, this is now defined as pre-heart failure for early recognition. Now, these patients have now progressed from stage A to stage B. These continue to be asymptomatic, but now have started to show structural and functional changes. The most common structural and functional changes you will see in these patients would be an abnormal either diastolic dysfunction or LV hypertrophy, atrial chamber enlargement. There will also be biomarker changes because of this, which would be an elevated proBNP, troponins will be elevated, and we could also see the urine albumin creatinine ratio. So pre-heart failure, now let's dive deeper into what the stage B is. This is an important stage because recognition of the stage could prevent the future risk of development of heart failure. Identifying these patients early provides a crucial window for prevention of irreversible changes. This is the early stage, and therefore is also more challenging because these patients are completely asymptomatic. Therefore, my presentation will just highlight why it is important to identify these patients, how we will go about identifying it, and how we should proactively treat them so that they do not enter the stage C and D of heart failure. So, we see so many of our patients who are at risk in the clinic. How will we differentiate if these patients have structural functional damage and need further interventions or not? So we have a risk score that was created. We all know the original, the Framinghams heart failure risk score, yes. So that initial risk study actually changed a lot. It helps us to identify a lot of risk factors. It came up with a risk score, but the risk score of that included mostly white cohort patients and did not include, and you needed more extensive findings to put in that risk score, which was like BNP, echo. If you'd already reached that stage, it's more difficult to assess. So there was a new model that was created, which is the pooled cohort equation to prevent heart failure. This is where you put like your basic traditional risk factors, and it produces a risk score, and the risk score helps to estimate which patients are at a higher risk of developing the disease. The 2022 heart failure guidelines actually endorses this model to estimate individuals' absolute incidence of heart failure risk for the next 10 years. This risk model also does not include non-traditional enhancers, so those are some things that we got to keep in mind when using this model. So this is actually the Med-Cal picture of the risk score that's there. So let's go over what do we need to put in. The variables here are age, sex, if these patients are current smokers or not, BMI, if these patients are currently on any hypertensive medications, what's the systolic blood pressure range is like, if they are on any diabetic medications, what's their fasting glucose, what's their total cholesterol, HDL-C levels, and the QRS duration. Any score that's greater than 5% has an increased risk, 10-year risk, absolute risk of developing heart failure. So these are the patients who would benefit from aggressive blood pressure lowering and use of specific therapies for more frequent surveillance. The limitations for this model specifically is that there is no specific antihypertensives that are mentioned in this or the anti-diabetic therapies and how they would affect the risk and the incidence of heart failure. And it also cannot determine between the heart failure of systolic dysfunction and preserved ejection fraction. Now, the diagnostic trend. We would see structural abnormalities in these patients who've developed the pre-heart failure stage. These will have left ventricular hypertrophy, cardiac chamber enlargements, ventricular wall motion abnormalities, valvular heart disease. There would be functional abnormalities like reduced ejection fraction, increased filling pressures, and abnormal diastolic dysfunctions. The abnormal biomarkers you would see in these patients would be elevated natriuretic peptides, more than 125, BNP more than 50, elevated cardiac troponins, and the elevated urine albumin creatinine ratio of more than 30. Now, the elevated BNP. Now, this is a predictor of heart failure. This was supported by the STOP-HF trial in 2023. This was a landmark randomized control trial, which was based in Ireland, spread over 5 to 7 years, and it took about 1,300 patients who were at risk for heart failure but had no heart failure disease as such. The interventional arm was getting BNPs normally, And if they were abnormal, they got imaging and intervention as needed. The control arm, if they had risk factors, was just treated till they were not treated till they were symptomatic. And in this patient, the 50% of the interventional arm came out to have abnormal BNPs. Therefore, they were followed up with imaging and then were started on ACE and ARB drugs. The primary outcome for this trial was that the LV dysfunction was about only 4% in the interventional arm and was 6% in the control arm. And heart failure exacerbations were about 1% only in the interventional arm, while it was about 2% in the control arm. This was also supported by a follow-up trial, which is the Pontiac trial. This is a prospective randomized control trial, which was conducted for about 150 patients with type 2 diabetes. And these patients were screened with BNP. Those with elevated BNP were randomized to having intense preventive care versus the usual care for the other arm. And at 2 years, the pro-BNP guided group had a significant reduction in MACE events, with the usual care arm, which had significant changes between the two arms. So the abnormal biomarkers we would see again would be elevated BNP, supported by those two trials, elevated tropes, and the elevated urine albumin creatinine ratio. Now, albuminuria was initially used just as a kidney metric. Now it's started to make significant changes, significant shift towards being used as a critical cardiac biomarker. The trials which now are supporting this is the renal trial, which is again a randomized control trial of about 1,500 patients, which showed about 2.7% increase of incidence of heart failure in patients who had albuminuria. Then there is the Frangeningham's offspring study, which was also a landmark study which supports the use of the albuminuria in heart failure. And the MESA study, which is a multi-ethnic prospective cohort of about 6,800 patients who had a higher incidence of heart failure across racial and ethnic groups, and urine albumin creatinine ratio was a prognostic information beyond traditional risk factors in this. Now, what would be the EKG changes we would see in these patients? I know this seems like a very overwhelming slide, and it is. So I'm going to break it down and try to quickly go over it. So the most important things we would see would be the elevated filling pressures. These would be changes we could see in the EKG. On the P wave, the P wave is made up of the right atrium and the left atrium. The red part would be the right atrial section, and the blue is the left atrium part. When there are changes in the right atrial enlargement, in lead 2, you would see tall P waves. These would be more than 2 mm in size. These are classically called as P pulmonale, signifying increased pressures on the right side. The left atrial changes would be also seen in the P wave. These would be seen as a dip in the P wave. P waves will be broader than usual, so more than 2 mm in size. This is classically called as M mitral, and it's a classic sign showing that there would be a left atrial enlargement. So you could see it in lead 2 and lead V1. Normally, these P waves are like 2 mm in size and would be normal, and in V1, it should be biphasic. If there is right atrial enlargement, they appear to be tall. In V1, they appear to be biphasic with taller on the upper side. In the left atrial enlargement, they will be the M mitral kind of phase, and they will be deeper on the lower side in V1. And this would be if both of them would be enlarged. The PR interval, you could see multiple changes in the PR interval in heart failure patients. This could be, if it's ischemic, you would see it would be prolonged. If it's infiltrative, it can cause your heart blocks. Inflammatory and infectious changes also can cause heart blocks, and drug metabolites that we use in heart failure patients also can cause PR interval changes, such as digoxin. Q waves, pathological Q waves usually indicate myocardial infarction, but even cardiomyopathies and infiltrative conditions can show changes in the Q wave. This is called like the paradoxical changes of Q waves. R wave changes, the upward deflection after the first P wave is called the R wave. It is the dominant R wave in V1, which is a classical sign for right ventricular hypertrophy. Commonly elongated VT changes and poor R wave progressions are signs of ischemia, which could later develop heart failure changes. QRS, the broad complex QRS, which is more than 120 millimeters, is required for a bundle branch block. So a right bundle branch block and a left bundle branch block are the two changes which can also cause cardiomyopathies. Left ventricular hypertrophy, this is high voltage QRS, meeting the voltage criteria based on the Sokolov lines criteria. There is also the non-voltage criteria, which would be the increased R, P wave peak time, which would be more than 50. And then the strain changes. The strain changes in these patients would be the ST depression and T wave changes. QT changes would be seen in digoxin toxicity, and there would be ST segment changes, which would be seen in ischemia, followed by T wave changes, which could be seen in beta blockers, LV strain, and Willen syndrome. If there were two things I would want you to take away from this overly filled slide, would be to focus on the increased pressure changes in the atriums, which would be could be seen in left ventricular hypertrophy, and in the left atrium and the right atrium enlargement changes and seen in P waves. Let's get to the structural and functional changes you would see on echo. So on echo, the first most common thing that we see is the EF, the ejection fraction. The normal ejection fraction, but a normal ejection fraction does not mean still that the heart is healthy. It could still have some underlying structural and functional changes, and also could have some diastolic dysfunctional changes which could be early. Now, how would you identify these? These would be seen as left atrial enlargement, classified as left atrial, the LAVI of more than 29, the increased filling pressures, which could be seen with the E to E prime more than 15, and left ventricular hypertrophy of more than 12 mm. There is like a 2 out of 4 criteria which is used for diagnosis of diastolic dysfunction. If there are more than 2 of these, it meets it's like the rule of 7. Basically, if their septal E prime is less than 7, lateral E prime of less than 10, this suggests impaired ventricular relaxation. An average E to E prime of more than 14 suggests elevated LV filling pressures. TR velocity of more than 2.8 centimeters also shows elevated pulmonary artery pressures and raised left-sided filling pressures. And the LVAI, as we discussed, high is a significant change for left atrial enlargement. Now, there is something called the illusion of EF, which is when patients have normal EF but still have structural changes underlying. This can be seen by your global longitudinal strain. It is basically used for early detection, for seeing subtle subclinical changes when our systolic function is still preserved. If your global longitudinal strain is anywhere less than 16%, it's usually represented as a negative number because it's basically the systolic contraction of the wall. So if any number that is less than 16% is classified as significant and a significant decline, and it would be a highly predictive of incident heart failure and would be very critical for cardio-oncologic monitoring as well. What's the role for cardiac MRI in these patients, and when would we use it? So what we see in cardiac MRI would be late gadolinium enhancement. Gadolinium itself is a contrast agent which is mostly extracellular and does not really penetrate healthy, intact cell membranes. The healthy myocardium simply washes it out and it does not retain anything, so it appears dark. This would be how the picture would look like, your myocardium. If we have an injured myocardium with some fibrosis, they will get trapped in this space and appear bright white, which is hyper-enhanced on the scan. So this late gadolinium enhancement is a sign of fibrosis and also a sign of underlying infiltrative cardiomyopathies based on the patterns that you see. How will you treat these patients now that we've identified them? It starts with the most basic lifestyle modifications, which is activity, diet, and maintaining a healthy weight, maintaining strict vitals, which means good control of blood pressure and cholesterol, and avoiding toxin substances such as smoking, alcohol, and drugs. So we identified these patients from the target population. These are going over all the patients with risk factors who have hypertension, diabetes, coronary artery disease, obesity, and then we will put them through the screening filters. After we've put them through the heart failure screening, once we decide on the patients, we would do the NT-proBNP on these patients and would also now include the urine albumin creatinine ratio based on the recent trials. Based on which patients fit the criteria, we could also do targeted imaging and genetic studies, apply to selected patients, and now what would be the treatment algorithm for these patients? Asymptomatic LV dysfunctional patients who have a reduced EF of less than 40% require aggressive treatment with ACE, ARB, and beta blockers. Device therapies such as ICD also could be used in patients with an EF less than 30% and have a more than 1 year expectancy still. ARNI and MRA currently do not have independent data to support these patients, so are not currently used. Type 2 diabetes and patients with heart failure risk factors, SGLT2 inhibitors have proven to prevent heart failure hospitalizations regardless of the EF in these patients. Type 2 diabetes with CKD and having a high urine albumin creatinine ratio, the interventions would be our ACE inhibitors, ARBs, and our SGLT2 and the newly introduced finrenone. The multi-system intercept. The diabetes and CKD by itself are potent independent accelerators of heart failure. Intercepting pre-heart failure requires therapies that act simultaneously across the cardiorenal and the metabolic axes. Heart failure, like type 2 diabetes, CKD, and heart failure risk, all of them could be affected significantly by SGLT2 inhibitors and finrenone. SGLT2 is effective in reducing heart failure hospitalizations, as well as in patients with reduced GFR, even in patients without heart failure with reduced EF. Finrenone, which is a non-steroidal MRA, has proven to improve cardiorenal outcomes and reduce heart failure events across patients with reduced GFR and having an elevated urine albumin creatinine ratio, especially in diabetic patients. The landmark trials which support SGLT2 use, even in these patients, has been the DAPA-HF trial and the EMPEROR reduce trial. The DAPA-HF trial has significantly shown an improved mortality in all these patients. And while the EMPEROR reduced clinical trial, if you see the empagliflozin is significantly doing better than the placebo patients. Now, we also have precision interventions in these patients with pre-heart failure. Device therapy can be used as primary prevention in patients with a reduced EF less than 30%, even after more than 40 days post-MI, or having a more than 1 year expected survival. Genetic cardiomyopathies, these patients require familial screening. So patients who have any relatives with genetic cardiomyopathies require aggressive screening of their family, especially first-degree relatives, and depending on the strain, also require follow-up screenings every 1 to 3 years. Then there is also cardiac amyloidosis, also other infiltrative diseases, which basically require very aggressive early diagnosis. These patients would have a disproportionate LV thickening and specific EKG changes, which could help us making early diagnosis and also having early targeted therapy like tafamidis before patients reach irreversible stage C with remodeling. So let's get back to our patient, the 58-year-old male. He was a patient with hypertension, type 2 diabetes, seemingly doing fine. He had an elevated heart risk score when we put it on the module. His biomarkers were elevated, more than 180. He also had, his EF was normal, about 52%, but had some global longitudinal strain when done on echo. It was less than 14%. Now, what do y'all think? What stage do y'all think this patient is in? And do we need to do any intervention? So let's start with just the stage.
What stage do we think?
So the patient has the risk factors of diabetes, hypertension, elevated BNP, and global longitudinal strain on echo.
Did I hear?
Okay,
gonna
yeah,
go
that's
B
right.
as in
It's
boy.
stage B, heart failure. So since this patient has been identified now as stage B heart failure, and he does have diabetes and has the risk factors, starting the patient on an SGLT2 would be the most appropriate measure, and titration of ACE inhibitors to achieve the goal blood pressure of 130/80 would prevent remodeling and the disease trajectory in these patients before they undergo irreversible remodeling and the symptom onset. My conclusion would be we require early screening for these patients. Routine annual biomarker screening should be done by primary care and endocrinologist. And identifying these patients early would really change our heart failure burden and would also help the patients as well. Educating these patients and having equal contribution by them would bring about significant change in the heart failure burden and its disease progression with its morbidity and mortality. Cancer screening is standard. Shouldn't we have like heart screening be standard too? This is something which is still not covered, and I think we should proactively move towards this stage. We still can get BNPs on these patients, but it would not be covered unless the patient is symptomatic. I feel like since cancer has an increased mortality, so does heart failure, we should have that in our part of our routine screening. I would like to thank my mentors, Dr. Heiner, Dr. Mahmood, Dr. Gross, and Dr. Amana. I would also like to thank all my friends who've completely supported me during this presentation. And these are my references. Thank you so much for being there.
Thank you, Dr. Ahmed. I'll remind you, if you're viewing online and have a question, please enter it into the Q&A section, and we'll ask that question for you. But here in the room, do we have any questions or comments for Dr. Ahmed? Okay, we have one over here.
First of all, can you hear me okay?
Yeah.
Okay. First of all, I want to say excellent presentation, Dr. Ahmed. I think that the comparison between cancer, because cancer is a very scary word, showing that it has similar mortality between HFrEF and, well, heart failure, if you take into account all the stages, plus cancer, if you take into account all the cancers, paints the picture beautifully. Is there any opinion that you have about maybe getting buy-in from patients as well for things like heart failure screening, talking about biomarker screening, things like that?
Sorry, I didn't get the last part. Could you repeat that?
Do you have any recommendations for generating buy-in from patients? Like, how do we convince them that heart failure screening is worth getting to in the office?
I think getting involvement with education which would be a great start. Educating patients, and especially even in stage A of heart failure, where they could actively make lifestyle modifications, can even prevent them from getting into stage B, where we need to do more aggressive methods. If patients are educated, they're also more proactive with getting these tests and trying to be more involved in their heart health and heart care. I would tell my patients just go through the ABCDs of heart failure. A would be aerobic exercise. Having 30 minutes of exercise every 5 days would make significant changes. B would be maintaining a good body weight and BMI. C would be avoiding anything like maintaining a good cholesterol levels, avoiding cigarettes. And D would be avoiding any drugs and preventing diabetes and having good blood pressure, diabetic control.
Thank you, Sana. This was a great presentation. I love the focus on primary care, of course. Along those lines, who would you, in an ideal world, suggest that we screen for, either with urine microalbumin, proBNP, or that calculator? Is it every patient who walks in, or should we should we screen the 19-year-old with no comorbidities?
This is a very great question because this is what most of the crux of this presentation is. How do you identify these patients? A lot of our patients we see in our clinic, all of them have the risk factors. Most of them belong in the stage A class category. How do we know who's in the stage B? To identify these patients, the risk module is the best thing. It's just on our app of the MDCal. You just put the basic parameters of the patient, the age, the sex, the BMI, the race, which actually makes a significant change in which patients are more at risk, and what is their blood pressure control and diabetes. If the risk score on that is more than 5%, it means that these patients are at an increased risk over the next 10 years. And these are the patients we need to catch. Even out of these patients, about 50% of them would be the ones who would eventually develop, but diagnosing them early and having initial interventions with appropriate medications like SGLT2 and strict blood pressure control can significantly reduce irreversible changes, and we can prevent them from going into those irreversible stages and having multiple heart failure hospitalizations in the hospital and all of that. So that's a great question, and the module would be the best place to start.
Great presentation, Sana. When you mentioned that ARNI and MRAs are not indicated for the asymptomatic LV dysfunction, why do you think that that's the case, even though they're one of the pillars for the stage C?
So the initial trials that were done for ARNI and MRA, which is the Paradigm trial, and I guess it's the Emperor trial, both of them were using patients which were with symptomatic heart failure with reduced ejection fraction. None of them used these asymptomatic patients who were there. There was actually a follow-up trial which was done after that, which was, I think, called the Paradise HF trial. And that trial was focusing on these patients who were asymptomatic, heart failure with reduced ejection fraction post-MI. And when we used ARNI in these patients, it actually did not show any significant change. So that's where this thing comes from, that we do not need to use ARNI and MRA in patients with who are not symptomatic with EF, like heart failure. Yes.
Great presentation, Sana. For those who are early in their training, what NT-proBNP, what's the threshold to say, when we start looking at biomarkers, what's the threshold to say it's heart failure versus pre-heart failure?
Yeah, so the NT-proBNP cutoff for patients to diagnose heart failure when we see them in the hospital is way higher. It's about 500, and that's when it goes red in the hospital. But when we do it in the clinic to diagnose these patients, our thresholds are way lower because we are looking for structural changes, which is causing the remodeling and which is causing our left atrial enlargement and causing those changes. So we would go for a cutoff of about 150. So these are the patients with 150 to 500 who have not become so sick with remodeling that they're symptomatic, but we are identifying them in early remodeling and we can make changes.
All right. Thank you, Dr. Ahmed.
Thank you.